Welcome to this next episode of Voices in Care. This is the podcast where I sit down with some of the exceptional clinical talent here at Apollo hospitals. We talk a little bit about their clinical experiences as well as anecdotes from their personal life. For this episode, it is my absolute privilege to introduce Dr. Rakesh Jalali. Rakesh is one of the most distinguished names in radiation oncology. He is currently the medical director and the lead of Neuro-Oncology at Apollo Proton Center in Chennai. With nearly 3 decades of experience, Dr. Jalali has dedicated his career to advancing cancer care through high-precision radiotherapy techniques, groundbreaking research, and a deeply patient-centric approach, and I hope to talk to him a lot more about this. Rakesh, thank you so much.
Thank you very much for having me.
You completed your MD in radiotherapy and oncology. You were at PGI Chandigarh. You completed that with distinction. And then Rakesh went on to pursue an advanced research program at Royal Marsden, the NHS Trust in London. He has authored more than 300 peer-reviewed publications in globally renowned high-impact journals such as the Lancet Oncology, JAMA Oncology, and the JCO. He is a founding force behind the Indian Society of Neuro-Oncology, the ISNO, and the Brain Tumor Foundation of India. His contributions have been recognized with numerous accolades, including the Best Oncologist Award by Medscape and several other awards in the field of oncology. Beyond his credentials and achievements, what makes Dr. Jalali truly exceptional is his focus on the human side of medicine. Something I know very well because, Rakesh, we've shared some patients. You've kindly agreed to take care of some patients that I've referred to you. He's tailored his treatments to individual needs. He empowers patients with knowledge to make informed choices, and his work continues to inspire, influence, and improve outcomes, not just for patients at Apollo, but across the globe. Rakesh, it's a pleasure and an honor to have you with us today.
Thank you very much, Madhu. It's been a great pleasure and privilege for me as well.
So, Rakesh, let me start by asking, why did you choose medicine? And then beyond medicine, I'm looking back to the days when you picked up radiation oncology as a field. So this is very early days of radiation oncology. So tell us a little bit about your personal journey into medicine and your choice of radiation oncology as a field.
Right. So medicine was not my first love, surprising as it may sound. I had a great interest in English literature and I wanted to become a writer. But largely my life philosophies and ethos were governed by my grandparents and grandfather in particular. And he had worked in the medical field for a number of years with the British, and it was one of his dreams that one of his children or grandchildren would become a doctor. And then once you joined an MBBS, of course, especially when you start going to the clinic, I just fell in love with the profession. I truly believe, not sounding cliched, but it is one of the, you can do literally anything. It's a scientific approach, but there's a great human interaction. You need fair amount of even the management skills these days, and the ethical part of it, the moral part of it, the humanity part of it. And what is spectacular in this field is that at the end of the day, in spite of all the algorithms and protocol-driven protocols and all this which governs your day-to-day practice, it is an art. So therefore, to me, that medicine is very much captivating and rewarding. As far as radiation oncology was concerned, it was very clear at the end of my final years and also in the beginning of the internship that two things fascinated me. One was clearly oncology related because that was still a formidable, and even after 30 years, it still is a formidable challenge. So that was kind of driven, and that really excited me when I was doing my final. And I was also quite captivated by imaging for some reason. In fact, I did my pre-residency fellowship and training in radiodiagnosis and imaging because I wanted to learn the imaging part of it. And then when I chose oncology, even that time, late 90s, early 1991, PGI Chandigarh had probably the finest program. And it was not only radiation oncology, it was actually comprehensive clinical oncology. So those 6 years of residency, 3 years junior and 3 years senior residency in PGI from 91 to 96 were really truly comprehensive. So of course you had the fulcrum of radiation oncology and Professor B.D. Gupta, who was one of the iconic names and very inspirational to change the whole spectrum of oncology, one of the forefathers of, and I was his last student. And then it also had a comprehensive, we had the wards, we did systemic chemotherapies also, we had the tumor boards, and you did right from ascitic taps to putting chest tubes and doing the lumbar punctures, doing all those lymphograms. And so it was really truly comprehensive oncology training. And then of course my core subject was radiation oncology. So this is the journey I have had.
No, this is fascinating. And I will tell you this, Rakesh, in every single interaction I've had with you, what comes through very, very clearly is this intense focus on the science, on the data, on evidence-based medicine, but always with that art of medicine, the humanity, which is always evident. So very privileged to have you on our team. So tell me a little bit about neuro-oncology, because when you chose to subspecialize, because subspecialization is still a controversial topic today, right? So when you chose to subspecialize, it was very early. What made you subspecialize in neuro-oncology?
That's a great question, Madhu, and thank you for asking me this. So when I was nearing my end of residency, as a radiation oncologist, what was the dream? The dream of a radiation oncologist was to identify the tumor, or what we call target, in a very nice manner, in a very accurate manner. We have the imaging tools to focus that and then deliver the radiation beams exactly at that spot. And that time the turning point was radiosurgery, stereotactic radiosurgery. And this was in mid-90s. And then I was very keen to learn the science and art of stereotactic radiosurgery. Interestingly, Apollo Hospitals in Chennai actually was one of the pioneers of stereotactic radiosurgeries in mid-90s. And many people don't know, after I finished my residency, I spent 9 months in Apollo Tenambet as a junior consultant briefly before I went to UK for my neuro-oncology fellowship. And Professor Michael Brada, who was and who still remains one of the key people to transform stereotactic treatment throughout the world. Literally, he was the pioneer with series of path-breaking research. So we were corresponding with him, we spoke with him, and then I was very lucky to get enrolled at Royal Marsden. And then he was, of course, a comprehensive neuro-oncologist. So, and I had this always passion, not only from the technical aspects of radiation, but also how to integrate it with systemic therapies, how to translate into research, how to translate into clinical practice on a day-to-day basis, eventually to the patient and their families. And that was an unbelievable experience because it taught me the intellectual integrity. I was again very lucky to be part of the Tata Memorial Hospital. By the time it had established it always was one of the best institutions in the country. So this is March, April of 2000. And fortunately, and surprising as it may sound even now, we had a choice actually at that time to choose 2 or 3 subjects as a dedicated field. And Dr. Katie Thinshaw, who is a pioneer, was the director at that time. So I chose neuro-oncology, and again, many people don't know, I did breast cancer also along with neuro-oncology for about 8 to 10 years. But large focus was on neuro-oncology. And I had this burning desire, and primarily propelled by Mike, and then 2 things happened. There was clearly a need of a very national organization to set the tone. And I was convinced that we had an enormous number of patients. We had the resources, we had the skill sets. And some of us in the Tata Hospital, 4 or 5 people, we established the Clinical Research Secretariat. The only thing was we had to put them into protocols in prospective fashion and to generate quality international level data. And I took the onus to do that for neuro-oncology. And therefore, it led to the Indian Society of Neuro-Oncology and many other forums and internationally recognized. I am at the moment president-elect of the Asian Society for Neuro-Oncology, which I will take over from 1st January.
Congratulations.
For 2 years as the president of Asian Society of Neuro-Oncology. And I'll give you 2 more examples. Quickly, me and some of my colleagues realized in India, and you have come yourself abroad for many years. It's not easy to practice. On one hand, you have this load of patients, whether it is Tata Hospital, whether it's Apollo, whether it is Ordinary Institute of Medical Sciences, Cancer Institute, RDR, CMC below. But then you also have this amazing opportunity of producing world-class data. The only thing is you have to organize yourselves properly, and you have to have the resources, and you have to put the processes in place. And we realize that one of the major issues in our country is the finance, of course, and also to organize in other parts of that. There may be Mumbai, Chennai, Hyderabad, Bangalore, but it's not all over the country. And also to get some kind of harmonization in the care. And that led to the formation of a dedicated charity. It's one of the few charities in the world which was run by a physician. So we started the Brain Tumor Foundation of India along with my colleague Dr. Rajiv Sareen. And now everyone knows about it. We spent hours and days and years on it. Two classic examples is we do this annual art festival every year in October, which coincides with the International Brain Tumor Awareness Month. And the two of our paintings have come on the pages of Lancet Oncology, done by children from brain tumors in India. And I was passionate. I did a patient support group meeting first Tuesday of every month, spent a lot of time with them. And I have learned more in those meetings with patients and families than sometimes you attend in meetings and conferences. You know that how it is. As simple things like how to control epilepsy, whether I should drive, what should we do later. So I'm very passionate about not only cancer survival, but cancer survivorship. It's not only the cure, it is the quality of cure, which is important. And that also led me to the current role of proton therapy, which we'll talk in a minute. But this is just to give you a sense of how the field has evolved over a period of time and my deep commitment to neuro-oncology.
So, and Rakesh, you've been a pioneer in many ways, not only with your choice of a subspecialty, but also, as you said, we are sitting in this phenomenal center, the Apollo Proton Cancer Center, and we will, of course, take our viewers through a quick tour of the facility. But very early on, you were convinced that proton therapy is an emerging field, and you were not only a strong supporter, but a key element of establishing this facility here in Chennai. And this was way before the science was very clear, right? So, and I think this is your conviction that it is not just surviving cancer, but the quality of the survivorship that matters. So tell me a little bit about your conviction in proton beam therapy even before the science was clear.
Proton therapy conceptually is not new in that sense. The idea of having proton therapy in the clinic was in 1948 by Robert Wilson. And then what happened was the proton, as compared to the normal conventional radiation, which uses electromagnetic radiation, travels with the speed of light and doesn't have a charge, it is neutral. Proton has a positive charge, and it has this unique facility and unique physical and biological characteristics that, depending upon the energy and the depth, as it traverses the medium for us, a human body, when you reach the tumor, at the end, it deposits all its ionizing radiation, which is tumoricidal, at one spot, and that's called Bragg's Peak, named after William Bragg, a great Australian physicist who won the Nobel Prize of it. And then you have this unbelievable phenomena, I call it waterfall, that literally there is no exit dose. So for the viewers, the conventional radiation will come here, it will treat, but we cannot control its exit. There will be an exit. The proton will enter, will have some entrance dose. It will treat where we want the tumor to be treated, and there will be practically no exit dose. And that's a dream for a radiation oncologist, because you can sculpt your doses, wrapping around the tumor when it is close to a critical structure, such that you spare the normal tissues significantly, and also in challenging cancer sites like skull base and other sites, where you cannot deliver the doses that you want with conventional radiation. This allows you the flexibility to do that. The modern proton is like a laser pointer, 3 millimeter, right? So there is no shielding needed. And the whole tumor or target, we slice it like a bread slicer into, say, 500 to 1000 layers. Supercomputers in the proton therapy facility the energy being 70 to 230 MeV, it takes this proton, goes to the deepest depth of the target that we draw on the computer. It treats that spot, treats that line, and then goes proximally layer by layer. We call it spot by spot, line by line, layer by layer. And this can be done within flashes of seconds. The computer technology is so advanced and so sophisticated. It does need a fair bit of peer review and rigor to make sure that this is done properly with physics and clinical side. But the beauty is that the machines became compact. The translation to clinical practice is so rapid, and therefore you have this renaissance, so many proton therapy centers coming up. I have been again very fortunate, and this is something I have to give it to Almighty or something. I got this sense that this is the time to start stereotactic radiotherapy. So in 2025, we started the program then in Tata. And then Neuro-Oncology was a niche area. We managed to get that onto international map, produce generation of series of path-making research, which are practice changing, especially in childhood brain tumors in terms of not only preservation of cognition and quality of life, but also molecular genetics. And I have done a fair amount of work with my colleagues. The third was proton was also potentially a game changer. And of course, no words can suffice the vision and fortitude and bravery, I call it, for our chairman, Dr. Pratap Reddy, who in 2012, even we were not sure at that time as a radiation oncologist, and he is a cardiologist come major healthcare force, tornado, whatever you call it. And he had that vision to have a proton therapy facility in South Asia, not only in India. There was no South Asia. And then I had fortunately at the same time written a project for Tata Memorial Hospital. So we're just interacting casually, and then one thing led to another, and therefore I joined. So I'm convinced that especially what we call, there's a proton and there's a proton, and we have the proton. It is called image guided, intensity modulated pencil beam technology, which does this small spot-like picturization. And all proton therapy facilities in the world are not like that. They're sometimes old, even in the United States. So it is very important for viewers and physicians to know that it's not just a proton. You have to have the proton. And we are very fortunate, it's kind of plateaued. And Apollo, howsoever I may say, just not because I'm an Apolloite like you, it truly is a privilege to work in a center like this, where you have absolutely no dearth or a barrier to have the latest technology, but also have that flexibility and bandwidth to create whatever ideas you have with your teams, actually translating it into meaningful clinical benefit for our patients and their families. So that has been an unbelievable journey as well.
Rakesh, your passion, your excitement is evident when you talk about the field. But so let me ask you, when you're not thinking about controlling protons and neutrons with tungsten rods, what does Dr. Jalali like to do in his free time?
Good question. And I like to travel, and we try to go to partly work, but then you try to spend time in different parts and try to learn and absorb the. I'm also very fond of art and architecture, so partly fueled also by the charity in Bombay. Actually, most of my free time was spent on the Brain Tumor Foundation of India work, and we used to raise about 3 to 5 crores every year and try to done. I have actually done a small movie. I was talking to some of your colleagues. It's an animation movie we made about 15 years ago. It's called Bust at Noma. It's about 11-minute film in 3 languages, where 3 characters in the cartoon undergo the scenes of whether surgery, radiation, and chemotherapy in a fun way with the cartoon. And it has been screened in several countries around the globe. It is still run by many hospitals, and we won the National Frames Award for the best social awareness category. So that was another fun part. Recently, in the last few years, I have become very fond of Tamil literature.
Oh, interesting.
I can't read Tamil, unfortunately. I'm trying to learn the language, but I read their English translation. And 2 absolute favorites are Jai Mohan and Perumal Murugan. Especially Perumal Murugan. It's my dream to meet with him. And he writes with so much passion. He basically writes, he's been a teacher, and I have read, I think, about 15 to 20 of his works. Primarily on the rural area of Tamil Nadu in different parts. But it's a very humanistic type of approach, and particularly from the farmers and how their lives are intertwined, and the social interaction with the families, and the urbanization, and the power of cinema, and the family atmosphere. It's just an unbelievable writer, one of the finest. I have had the honor of treating, I can't tell you the names, some of the premier playwrights also of the country, and some film stars, and so art that way has been one of my passions, and they also share my enthusiasm about Perumal Murugan. And Jaimon is another one of my, he's from Nagarcoil, and he is also one of my favorites. And I also fond of a girl called Aparna Karthikeyan. She also writes quite nicely, and she, particularly in one book, she writes about 9 rupees an hour. So she talks about different professions in rural Tamil Nadu, ranging from Kanjivaram silk saris to making toddy, to making glass bangles, to making all kind of, even the troops, the dance troops who are looked upon, and they go from village and village.
Yeah.
And the minimum wage is 9 hours an hour.
Yeah.
And she weaves the stories intertwined with, it's in a fascinating manner. So whatever little time I get, I try to indulge in these things.
Interesting. You know, Rakesh, you've dedicated your life to medicine. It's time consuming. I don't even want to ask you how many hours you spend a week. But today we are in a very difficult time in medicine where the younger generation is somewhat disengaged, very frustrated, and many of them are burnt out. What's your advice to the next generation and the current generation of young physicians? How should they look at a career, and how should they balance work and life?
I do believe somehow medicine needs a little bit of self-introspection and reflection. In a way, when we even do the rounds or you ask questions, the residents are ready with the answers because on the Google. But both of us know we have gone through that, and I call it, it's called intellectual tapasya. You have to go through that fire, and that reflection is somehow not there. And in that sense, the endpoints are also becoming a little bit quick fix.
Yeah.
And they want an instant reward and gratification.
Yeah.
Even I have seen in Apollo, you being the CEO, it's my duty to tell you also, people expect within few years only to get an under emolument or to get a raise and to do this. While we somehow have not gone through that, we have really gone through a very sedate by current standards, and then achieved a little bit of value over decades of, without asking. In that sense, actually, Lord Krishna's karma theory is quite relevant. That don't look at the fruit, just look at the effort, and the fruit always be good. So the advice is that you be active, because you can't be without information and internet. But at the same time, you must try to organize yourself in such a way that you have time for yourself, but also to your profession in terms of tapasya and reflection and thinking and collaboration in a meaningful manner. And also be focused. Sometimes also they lose focus very quickly. I also feel that we were taught the art and value of perseverance in one field in a dogged manner. And then if you have chosen a path, then just don't give up so soon and change the path and do things, this is not working out. So the key is not to find an easy solution. The key is to find a joy after a nice hard struggle. And the joy that you get is unbridled rather than instant gratification, to my mind.
Well, that's fascinating, and I share a lot of your viewpoints. You talked a little bit about organizing the practice of medicine, and one of your early innovations, which I think is remarkable at the Apollo Proton Cancer Center, and in some ways unique in this part of the world, is this multidisciplinary cancer care team that is focused around the patient. I can imagine how incredibly important this is for pediatric tumors, childhood tumors, but every cancer patient, we get them at the most vulnerable period of their life. And you've wrapped all of the specialties around the patient rather than making the patient go between sites and seek the next consult. So tell me a little bit about your philosophy around multidisciplinary care and organ-specific or cancer-specific care.
Right. So in medicine, and oncology is a prime example, and it truly kind of exemplifies the spirit of multidisciplinary approach. No one physician can treat or cure cancer. And when chairman and Ms. Preeta Reddy and others asked me to join Apollo in 2017, I wrote up actually a vision document to the chairman. And then one of my major requests was that Proton should not be standalone, because there were some experiences, especially in the United States, that if you have a standalone Proton, it won't work. It sometimes have gone belly down and other problems have happened. So it has to be integrated in a cancer. So it's a dedicated cancer center, comprehensive Apollo Proton Cancer Center. But also we must work in an organ specific, and that is the differentiator. And we don't need to reinvent the wheel. All major cancer centers in the world, both in Europe, US, Japan, even in India, Tata Memorial being one of them, have thrived only because of strong ethos of cancer management in a multidisciplinary unit being the fulcrum of their care. So therefore, I proposed a model which is called cancer management team. And this was primarily derived from erstwhile models called disease management groups. Now, I didn't like the word group because there were Facebook groups, Insta groups, and team is team. So I wanted to put the cancer word because the Proton Cancer Center was also, there was a lot of thought actually gone behind how we call it CMT. And I must admit the amount of support and chairman's joy and Ms. Preeta's vision, because they had tried this many times, I think. That's what the feeling I got, and were not really very successful. And we can understand the dynamics of the workplace and so on and so forth. But at least this was a greenfield project. This was right from the start. Proton was the fulcrum, but we were doing the whole cancer management scene along with it. So right at the beginning, we devised 8 or 9 cancer management teams. And first job of mine was, unfortunately, I joined when there were still walls being built. And they were, again, see the flexibility of the promoters, and quickly we designed the outpatient structure, that not as a surgical oncology, radiation oncology, medical oncology, like the usual cancer center facility anywhere in the world, but we made 8 clusters of head and neck team, where the head and neck surgeon, the radiation oncologist, the medical oncologist, speech and swallow therapist, and the dentist will sit at one place. And neuro-oncology, where I sit and my neurosurgical colleagues sit, our fellows sit, the clinical endocrinologist, the clinical psychologist, and the neurologist, whenever they come, they have that space. You have the breast cluster, you have the pediatric cluster, you have thoracic, you have the gynec, bone and soft tissue, and urology. So we got those clusters. And the patient, when he or she is getting registered, they don't get registered in one doctor's name, which is the usual norm in most of the hospitals. They get registered also in that cancer management team. So it's a CMT, and initially actually we had color-coded CMTs also. And therefore, the focus on clinical care, education and training, the practicums, the specific care, but also with human touch, spending hours and hours on each and patient and family, along the weaving of the fulcrum of cancer management team with a strong focus to publication, should be the mantra of any cancer center.
Talking about cancer center, we are lucky to be in this amazing facility. Can we just take a walk and maybe show our viewers the proton beam? You have a 3 gantry proton beam installation. So shall we go take a look?
Madhu, welcome to the proton therapy facility at the Apollo Proton Cancer Center in Chennai. And this is the proton corridor. We have 3 rooms where we treat. At the end of the corridor is the cyclotron. I just want to stop by and show you this beautiful piece of artwork. This is drawn by our patients and children because they need an immobilization mask for every day.
Yes. And
at the end of the treatment, we have this fun activity with them, with our therapist. And there's actually quite a bit of artwork, but as a sample, we kept some of them. And every time a child or a patient comes, they get inspired by this lovely piece of artwork.
It's truly a story of our survivors, isn't it?
That's true, yeah. That's true. And at the end of the treatment, when they do, we always have a bell of cure. So may I ask you to, yes,
of
you
course.
Can bring. So this is the bell of cure for our cancer patients. Yes. And this is the actual gantry machine. There is a lot of things which happen actually behind the machine.
Yes.
But to make it patient centric approach and patient friendly, it's a paper-free environment, by the way. The first thing they do is, if you can focus here, please, they can select the color of the room, they can select the animation the children want to see, and they can also select the music. Interestingly, recently we had to put Korean music because a lot of our young teenagers wanted Korean music.
Yes.
So we have the whole plethora of classic, jazz, local, Bollywood movie
and
songs
K-pop.
To there. Now, if you can see, this is the actual proton therapy machine, and it is 3 times bigger at the back. But the patient doesn't realize this, and we have a group of therapists who actually rotate the gantry. Many of the gantries in the world, they do not rotate 360 degree, but this is state of the art. It rotates 360 degree. This is a robotic couch. It's a highly precise couch, and the patient lies down here for about anywhere between 10 minutes to about 20-30 minutes. And then we make sure that we are treating the right position. And once it is done, the therapists go out. There are television cameras, and we switch on the beam, and the patient is treatment. Absolutely no pain, completely patient friendly. This is truly not only from therapeutic point of view, but also from an aesthetic point of view, a reasonably pleasant experience from treatment point of view.
So Rakesh, there is this sense, right, that among patients that proton therapy is an elite form of therapy. It is very, very expensive, that it's out of the reach for many patients. What do our patients and our referring doctors need to know about this modality?
Yeah, thank you again for asking this question. It's a very important question. It is true that proton therapy does need a fair amount of resources, both the human resource, the training aspect, but also quite a bit of material resource. You have to have that footprint, you have to have that space, and a lot of dedication. And I truly believe human resource also very important. I'll tackle the human resource part first. So right at the beginning in the year, even when we had done 200 odd patients, we started an online program called Apollo Proton Practicum, and that has become a global phenomenon now. Every year we do it. We invite a key player in the world to give Dr. Pratap Reddy proton oration, and it has been a huge experience, and we have done already 5 such practicums. This year we attracted 750 people from 32 countries all over the world, and I'm very happy that you not only blessed us but also participated in 1 or 2 practicums. Yeah, it was great. So that is the education resource point of view, and that is also education for referring physicians. To some extent, it is still because of the investment and also the high level of technical expertise, it still is not so much prevalent as it should be. But fortunately, it is growing. Now we have about 130 to 140 proton therapy centers in the world. It is estimated based on current clinical evidence, the percentage of patients who qualify and who get access to this facility is about anywhere between 2 to 3 to 5%. But in the next 20 years, this number is likely to grow by 25%. The reasons are the clinical evidence is mounting. There's a great deal of collaboration throughout the world to push the field. Number 2 reason is the footprint is actually decreasing. The investment cost is decreasing. As you probably know, we are going to embark on at least 2 more proton therapy facilities. And we estimated in our country, actually we need roughly about 15 to 20 proton therapy facilities in the next 15 to 20 years. And our chairman is already talking about that number as well. So, and that is the case in other parts of the world as well. So as the numbers will increase, definitely the cost is going to go down because the running cost is also very high. We also have 2 other important aspects. One is for pediatric patients in particular, and adolescent and young adults. There's a fair amount of activity which does the fundraising. We also have flexible protocols to take care of whether it is 5 fractions versus 15 fractions versus 25 to 30 fractions. So that takes care of the cost. I must say, no patient in Apollo has ever gone back just because they can't afford. Whatever it takes from the promoter family, from our management, from the clinical team, if the patient or the child does require proton, there's a very strict proton peer review process which goes on, not only in the tumor board within our hospital, even in our radiation oncology and medical physics group every day in the morning. That meeting is called ISO center meeting, where we evaluate whether that qualifies. So that helps. And finally, which has been emerging, and it is one of my favorite subjects, is what we eventually need is democratization of proton therapy. And that will happen, I'm sure it will happen, it's already happening. Major vendors are trying, and that is not only for proton, that is for robotics, that is for high-end genomics, that is for next-generation sequencing, and also for immunotherapy, for example, and targeted therapy. As you probably know, I am deeply involved in immunotherapy also. That's another facet. Although I'm a radiation oncologist, but I have great fascination for immunotherapy, and we have a very vibrant Immuno-Oncology Society of India. I just took over as the president of the Immuno-Oncology Society of India also for 2 years this year. And we are going to host the next Immuno-Oncology Society of India meeting in Chennai in January. It's always in January. And this year we had Jim Allison, who won the Nobel Prize for immunotherapy, who came down to India and spent quite many days with there. So all these aspects, we need democratization. And that will come with more numbers, quality, intellectually honest data, but also dialogue with the industry, dialogue with the healthcare planners, dialogue with the patients, dialogue also with patient advocates, philanthropy, and not to talk about government. So all the 5-6 stakeholders, if they come together, I'm sure, and any cancer high-end therapy, including proton, will become much more accessible and much more affordable.
Rakesh, thank you so much. I've truly enjoyed this, enjoyed the opportunity to learn more about the science, more about you as a person. I'm very grateful for your dedication to the field, for everything that you've done for Apollo and for our patients. I think a key takeaway for me today is your line that it's not just about surviving, it is about the quality of the survivorship. And I think this modality, what it does, based on what you've told me, the waterfall, the limited area of involvement with beam therapy, is that it improves the quality of life for our patients. And truly, it is a moral imperative to get this out to more patients. Thank you so much. It's been truly a pleasure and an honor to engage with you.
Thank you so much, Madhu, for having me today.